Hello and welcome to today's Office of Behavioral and Social Sciences Research webinar titled Residential Age Stratification Effects on Older Adults' Well-Being. I'm Erica Moore, Communications Director of OBSSR, and I will be today's moderator. On behalf of OBSSR, I would like to thank you all for attending today's session. The agenda for today's webinar is simple. In a moment, I will introduce today's speaker, Dr. Sara Moorman, who will present on a project that proposes the age composition of neighborhoods is a key contributor to health and well-being in mid and later life. The presentation will be followed by a Q&A session during which we will answer your questions. Joining me and Dr. Moorman to answer your questions is Dr. Bill Elwood, Health Science Administrator at OBSSR. Before we begin, here are a few logistical announcements. Could you advance to the next slide, please? Today's webinar is being recorded. All phone lines will be muted during the webinar. Questions and comments will not be taken via phone, but will be taken via the Q&A feature located at the top right corner of your screen. You can ask a question at any time. To ask a question or send us a comment, click on Q&A at the top right corner of your screen, select Ask All Panelists, type in your question, and hit Send. We will try to answer as many questions as we can. In the interest of time and to make sure we take as many questions as time permits, we will take a single question at a time from any one participant. Now to introduce today's speaker. Sara Moorman, Ph.D., is an Associate Professor of Sociology at Boston College, where she holds a joint appointment with the Institute on Aging. She has been at Boston College since 2009, when she completed her Ph.D. in Sociology at the University of Wisconsin-Madison. She is a fellow and a member of the editorial board of the Journal of Research on Aging. Moorman's other major line of research investigates decision-making at the end of life, with attention to family relationship quality. She is currently beginning new research on mild cognitive impairment as a function of risk originating in adolescence. I am now turning the webinar over to Dr. Moorman, who will now begin her presentation.
Thanks, Erica. So, as Erica said, my presentation title is Residential Age Stratification Effects on Older Adults' Well-Being. And sociologists, as I am one of, typically study disparity or inequality by factors such as race, class, and gender. That's sort of our holy triumvirate. And in this project, I'm looking at health disparity by age. Age is a lesser addressed category relative to race and gender, because, for one thing, people move through age categories over time, whereas socioeconomic mobility is less, and gender and racial mobility very little at all. And secondly, because or although older people are vulnerable, most people prefer being in the vulnerable condition to being in the dead condition, which is the other option. So fewer people look at age as a social stratifier within society. Now, when I say age segregation, I'm here talking about segregation strictly in the sense of isolation or separation, without necessarily applying any kind of connotation to it, positive or negative, yet. We'll get there later. So scholars such as Hagestad and Muhlenberg have talked about three different types of age segregation. One is institutional, where age is a criterion for admittance. Things like your birth date has to fall by a certain time in order for you to begin kindergarten, and your birth date has to fall at a certain time in order for you to be eligible for Social Security benefits, and so on. Cultural age segregation is the extent to which age is a marker of lifestyle. So if you think about the last album you bought and compare it across people of different ages, you probably find differences there. And the third way, and the one I'll be talking about most today, is spatial age segregation, where age is determinant of where people spend time, where they have their physical location. So going back to the album example, we would think about going to concerts by those artists, that those are age-segregated spaces, or if we think about the institutions such as kindergarten, those are also age-segregated spaces. Another example I like to give my students is the grocery store. Everybody goes to the grocery store, right? But people go to the grocery store at different times of day and different times of the week, depending on age. So I have to think about who's at the grocery store at 9 a.m. on a Friday versus who's at the grocery store at 5 o'clock on a Friday. So, theory, we expect age integration, that is the opposite of the segregation that I was just describing, to be good for the health of older adults, because we expect that age integration will prevent social isolation, that age integration will allow older adults to keep up with technology and changing culture, and so on. We also expect age integration, theoretically speaking, to be good for the health of children, because more interaction with older people, adults and older adults, means more mentors, more teachers, more contact, more support. And therefore, the theorists who talk about age integration, who include Matilda Riley, sort of conclude that age integration should be theoretically good for just about everybody. However, empirically, there's a big black box. Although a variety of theorists have talked about the health benefits of age integration, empirically it's been very little tested. There are some European data on social networks. So taking a social roster and saying, okay, who are the people who are most important to you, who's closest to you, who do you have the most contact with, and then asking the ages of those people. And in the European data, we've found that networks are highly age segregated, with family ties being almost the only intergenerational ties that people have. So if, for example, you're a 75-year-old woman and you list an important social contact who's under the age of 35, that person's probably a family member. We don't, or at least didn't when I started this project, have this kind of data in the United States. Now, with the release of the first few waves of the National Health and Aging Trend Study, we do have one study that has social network data with ages. But when I started this project, we didn't. What we had was administrative data on spatial age segregation. Specifically, we have the census. And the most recent census is the 2010 census, which covered every American household with a 10-question form that included their age, and then aggregated that information to various different geographical contexts, where the ones that neighborhood researchers use tend to be the census tract. It's just a subdivision of a county. They're always nested within counties. Census tracts are designed to be relatively homogeneous with respect to demographics, economics, and living conditions, and they're all supposed to be approximately 4,000 residents, which means that census tracts are physically bigger in less populous parts of the country, like Plains area, Great Plains area, and they're smaller in cities. So, for example, this is the census tract where I'm talking to you from right now. And some of the strengths of this particular census tract is that it's very walkable. To go from east to west in the census tract, about half an hour walk. And it has boundaries that people recognize widely as being neighborhood boundaries. So to the north, Commonwealth Avenue; to the south, the D line of the Green Line, if you're familiar with that at all. So it's a pretty well-defined neighborhood space. It does have, the census tract, though, some weaknesses that are shown in this particular example, one of which it bisects campus. So actually, I said I'm in the census tract, but I'm actually a little bit to the left of that far line, because the Boston-Newton city line is bisect campus and census tract nest within larger units, like I said before. The other thing, this particular census tract is not so socioeconomically homogeneous. Up on campus, we've got Boston College students living in the dorms. Over here by the reservoir, Big Poppy has a condo, and I've seen pictures of it, and it's not much like the dorms. So what we know based on census tract and other census unit analysis from prior research shows that age segregation is comparable in scope to the neighborhood segregation of Hispanic persons in the United States. This is work by Rochelle Winkler and some of her colleagues. And she found that at the county level, 43% of people would need to move to change neighborhoods in order to evenly distribute people by age. So what I did in this project was I started out with the age distribution in the United States. So for instance, in the U.S. as a whole, 18.5% of people are age 60 or older. And so this is also true for, the percentages of people in different age groups. So there's people 18 to 24, 24 to 34, so on. And so we looked at the distribution by age group and said, okay, there are going to be standards in which we're going to call these neighborhoods representative or non-representative. And I'll show you some slides later in which I picked one plus or minus 1 or 2%. And for most of this research I picked plus or minus 5%. So I'm saying that a neighborhood is representative of people 60 and older if within that census tract between 13.5% and 23.5% of people, residents, are older adults. So to look at this next slide, I categorized a few different types of neighborhoods. One of these neighborhoods that are age representative, where it has between 13.5% and 23.5% of older adults, plus representations within plus or minus 5% of younger adults, and what my students and I have been calling families, which is adults aged 30 to 49, and their presumably their children aged 18 and under, such that we created this typology where about a third of people live in age representative census tracts, then a chunk of people that live in census tracts that overrepresent families. So that's that 18.84%. Those are neighborhoods that have more than you would expect, more than 5% above the national distribution of persons aged 30 to 49 and their children. Then there's a chunk of neighborhoods that overrepresent young adults. Those are adults aged 18 to 24. And there's a good chunk, almost a quarter of neighborhoods overrepresent older adults, so people aged 60 plus. And then there's about 10% of neighborhoods that can't quite be evenly categorized. They aren't normally distributed. They're not evenly distributed, but they're also not quite easily identifiable either. So I'm going to show you a couple of maps. And keep in mind that these maps are definitely not to scale. I showed you how small a census tract was. So these dots are many, many times too big. But they can give you a kind of a sense of the distribution of neighborhoods across the United States. So you will see a very small number of red dots. In the U.S., there's only 88 of them. And those are dots that are within plus or minus 1% of the lower 48 states' age distribution for all the different age groups. So these are highly age representative neighborhoods. And they don't have much of a spatial pattern. However, if you look at the blue dots, which are neighborhoods within plus or minus 2% of the lower 48 states' age distribution for all the different age groups, you see some more clustering. So Midwest, Southeast, Northeast, California, West Coast, but fewer dots within the middle of the country. This is another map of extremely age-segregated tracts where, for instance, the red dots are neighborhoods that are 75% or more people aged 18 to 24. So those are pretty classic college neighborhoods. You see Madison, Wisconsin on there, State College, Pennsylvania, and Ann Arbor, Michigan, and so on. The blue dots are neighborhoods that are 75% or more families. Again, those were adults aged 30 to 49 and their kids. And so you see those, some clusters in Texas, one in Utah, and so on. And finally, the green dots are census tracts that are 75% or more persons age 60 and older. And you see that those are distributed across the Sun Belt, so California, Arizona, Texas, and particularly in Florida. So that was our first step, was to describe the U.S. in terms of age distribution and spatial age segregation. But that's really only interesting insofar as the distribution means something for people's well-being. So I moved on to the second question of, does neighborhood age segregation matter for people's well-being? And here we have to change analytic approaches somewhat, because this doesn't ask anything about health. So my hypothesis here, going into the project, is that neighborhood age segregation would in fact contribute to the health and well-being of residents of all ages. And why? Because what Hagestad and Eulenberg and Riley and other theorists have said is that age segregation changes the nature of social interactions people have with the persons around them, whether that's in the grocery store, or the neighborhood, or at a concert, or where have you. And I do want to point out that this hypothesis doesn't specify a direction, and I don't think that exactly which direction it should take is obvious. The theorists say that age segregation should be bad and age integration conversely is good for health and well-being, but we also know things like retirement communities are extremely popular. So on a couple slides ago when I showed you the extremely age segregated tracts, and there's those tracts that are 75% more or more older people, those are places where people are retiring and having a wonderful time. And so to the extent that people do seem to choose age integration, I think it's an open question, or age segregation, sorry. I think it's an open question whether segregation or integration will be good or bad, which is a thing that I think is interesting about this research question, insofar as a lot of neighborhoods research is pretty directional. If you're studying socioeconomic status or you're studying social disorder, you have a pretty good idea that social disorder is going to be bad for health and other kinds of outcomes. So this question is interesting to me because it could very well go either way. To mention a little bit about neighborhood as a social context, we know that older adults spend 3/4 of the day within their neighborhood. Now, some of that may be in their houses or sleeping and not interacting with neighbors, but we also know that older adults have the highest levels of socialization with neighbors and involvement in community activities. So older people should be heavily influenced by what sorts of interactions they have in their neighborhood. And my research team and I got together to think about, well, what kinds of interactions could possibly happen. One kind is that it could be negative interactions. You could have what we call daily discrimination, or some people refer to this using the word microaggressions, but kind of low level, the questions in the scale are things like, how often are you treated with less respect than other people, and how often do people act as if you're not smart? So we're not talking about physical aggression, we're not talking about high levels of discrimination such as being fired from a job. We're talking about sort of everyday irritants that make you feel less about yourself. So that could be one possibility. Another possibility is opportunity for generativity, which is a concept we talk a lot about in gerontology, where older adults have the opportunity to teach, mentor, guide younger persons. And here we're talking about younger persons of all types, children for sure, but people in other generations generally speaking. And finally, another possible outcome of interaction could be social integration, or the extent to which neighbors trust each other, feel safe in the neighborhood, feel like it's a community, and so on. So we said, okay, those are 3 possible things that could happen. And we did, accordingly, 2 studies. In this first one, we looked specifically at daily age discrimination. And I said that census doesn't measure health. So what we did here was we geomatched the census data on age distribution and took a couple other measures such as racial ethnic distribution and socioeconomic distribution, and matched that data to representative survey data from the National Survey of Midlife Development in the United States. Specifically, we used Wave 2, which was 2004 to 2006. And in that study, for this particular analysis, we took the participants in LIDUS who were age 60 and older, of which there were a little over 1,500 of them, and they were living in a little bit under 1,500 census tracts, so there was a small amount of nesting there. Our outcome was daily discrimination, so those questions I read to you before, plus others about respect and so on. And these are people who said that at least among the reasons that this happened to them was their age. And finally, our key independent measure was the percentage of tract residents who were age 60 and older. Now, in the next study, I will be using the input topology that I showed you earlier, but here we're using percentage of census tracts in linear fashion because I'm going off of group density theory, which is a theory I borrowed from the race ethnic literature, that the premise here is that despite the concentration of the disadvantages of low status, such as material hardship and isolation that are created by residential segregation, it's also the case that enclaves of similar residents, such as people of similar age, could also entail certain advantages. So, for example, older persons who live among other older persons should be protected from exposure to age discrimination because older people, presumably, aren't going to discriminate against each other, whereas being surrounded by younger people might open older people up to the possibility of age discrimination. I should mention that in this talk, I'm going to skip over many of the methodological details, such as what controls I used and what kind of modeling strategies I used, but I'm perfectly happy to take questions about that. So these were our results from this first study, which did in fact show support for group density theory, particularly among people in their 60s. So you see that among people age 60 and older who lived among a low proportion of older adults, where a low proportion of older adults is 2 standard deviations below the mean, had a 50% chance of experiencing daily age discrimination at the age of 60, whereas 60-year-olds who lived among a high proportion of other older adults, and that's 2 standard deviations above the mean, had only a 15% chance of experiencing daily age discrimination. And people who lived in an average type of neighborhood had about 30% chance. And then you see that 3 lines converge, such that by the time you're about 77, it doesn't matter what your neighborhood context is at all. You are equally likely, or rather unlikely, a little over 20% chance of experiencing age discrimination. Now, I'm not sure which one of the reasons it is, but I have 3 possible reasons why this could be. One could be that people perceive less age discrimination as they get older. So we know that there's various cognitive changes such that older people exhibit a positivity bias. They pay more attention to things that are positive, they ignore things that are negative, which is very good for emotional stability, but is maybe not so good for your reporting of objective age discrimination. Although it could be, and this is the second possibility, that people really truly encounter less age discrimination as they get older. We know from socio-emotional selectivity theory and the empirical work behind that, that people trim their social networks and get rid of irritating social ties. So it may be that people are able to protect themselves from age discrimination in various ways. The third possibility is it could be a selection effect. It could be that the people who experience age discrimination drop out from a sample either through death or refusal to participate in the later waves. So that also is a possibility. In the second study, we did a complicated path model that includes the three possible types of interaction that I talked about before: generativity, discrimination, and social integration, as mediating the association between neighborhood types and multiple outcomes. So here is where I use the neighborhood types that is representative of all age groups, overrepresents older adults, overrepresents young adults. There's a category of few young adults. There's a category that's simply other, and these are all with reference to neighborhoods that overrepresent families. Again, those adults who are 30 to 49 and their children. So here again, I geomatch the census data to data from MIDAS. But here I use the entire breadth of ages in the MIDAS sample, which is 30 to 84 at wave 2. And so there's 4,000 participants in study who are living in about 3,700 census tracts. I told you about neighborhood topology. As far as the dependent measures, we use the 43-item Rick scale of psychological well-being, which includes dimensions such as self-acceptance, autonomy, personal growth, and personal control. And I use the standard single-item measure of self-reported health that scales excellent, very good, good, fair, poor. So we're measuring the mediators, the loyal, the generativity scale, 6 items, the 9-item scale of daily discrimination, which I believe is designed from MIDAS, and a 3-item scale of social integration, all of which have adequate reliability. In terms of self-reported health as an outcome, 3 significant indirect effects. So ones whereby neighborhoods were neighborhoods where people could experience generativity, and places where people could experience generativity in turn were places where people had better self-reported health. And I should note here that this is people of all ages in that 30 to 84 range. So we're not strictly talking about generativity among older adults only, and this effect isn't limited to older adults. And then the second and third indirect effects were that relative to family neighborhoods, representative neighborhoods and neighborhoods that overrepresented older people, the neighborhoods that had the highest levels of social integration, and social integration in turn was associated with better self-reported health. And I think this one is interesting because on the simple principle of aggregation, you would assume that neighborhoods that overrepresented older adults would be neighborhoods that have lower self-reported health, just because you have an accumulation of people in poorer health. So the fact that the association was actively in the other direction, I think is really interesting. Somewhat similar results with regard to psychological well-being. First, that relative to neighborhoods that overrepresent families, age-representative neighborhoods were places where people had experienced more generativity and thus better psychological well-being. And again, in representative neighborhoods and neighborhoods that overrepresented older adults, there were higher levels of social integration and thus higher levels of psychological well-being. So from this study, we concluded that age structure of the neighborhood is related to the types of social interactions people have with their neighbors, particularly in terms of generativity and social interaction, or social integration, sorry. And these day-to-day interactions with neighborhoods are in turn associated with people's health and well-being. There's two limitations I should mention here. One I introduced earlier is the extent to which census tracts are and are not a good representation of lived experience in neighborhoods. Second point is that the MIDAS data were collected on average in 2005. They were collected between 2004 and 2006, whereas I matched them with census data from 2010. So in parts of the country where population change is rapid, the census figures might not match up very well with the MIDAS responses. A third concern is that cross-sectional data limit causal claims, and of course limit the extent to which I can talk about things like moving. That is, why would people choose a retirement community? Would it be actively to get away from age discrimination or some sort of interaction like that? I cannot tell. Study. And finally, the study has relatively limited nesting of individuals within tracts. So there's little leverage on the neighborhood context, whereas a study of a few cities might tell me more. In terms of implications, we have some for theory, practice, and policy. In terms of theory, I think there is an open question about whether, in some contexts, spatial age segregation is good for people's health and well-being. So in the age density paper, I found that people are less likely to experience age discrimination in nested neighborhoods. I also found that in highly age-dense neighborhoods, people have more social integration relative to family neighborhoods. So I think it's an open question, and that there might be cases in which age segregation is valuable and important for people. I think the conclusion for practice has to do with whether interventions can alter the types of intergenerational interactions people have in age-integrated neighborhoods. So we know, again, borrowing from the race ethnic literature, that when people from different racial and ethnic groups are brought together to collaborate on a project in which they have a shared interest and they can both bring things to the table and interact on an even playing field, that interactions of that type are interactions that decrease stereotypes and racism. And so presumably intergenerational interactions model on the same sorts of principles, that is, a shared interest in an activity, both able to bring things to the table, and so on, would permit age barriers to break down. And given the interest a lot of communities have in pairing retirement centers with kindergartens and schools and child care centers, other kinds of interaction like that, I think that has implications for the way that those programs are designed and administered. And finally, for policy, I think there's an open question about whether public health policy should work to promote aging in place, which is staying in the neighborhood in which you've lived your adult life in the community, or aging within designed retirement communities that have, physical safety features, universal design, and so on. I think many communities see older adults as a liability in terms of community safety, things like sidewalks, curbs, shoveling snow, and also in terms of the health resources that older people frequently need, versus seeing older adults as a resource, where here I've shown that a high proportion of older adults actively increases social integration in neighborhoods. So I think the neighborhoods, communities can move away from thinking about a deficit perspective on older adult residents. So those were my research conclusions, and I'm very happy to take questions.
Thank you, Dr. Moorman, for such an informative presentation. Let's begin the Q&A. Do you want to go? Yep, thank you. Next slide.
Perfect. Thanks so much, Sarah. Regarding the participants, do feel free to type your questions into the chat box. While those are coming in, I'm wondering, in regards to your recommendations, what examples do you know about that attempt to cross that, to bring together generations, particularly when there are so many housing complexes and developments that are targeted specifically for seniors?
So this is anecdotal. I'm not involved with programs myself, but I know that I have read and seen on YouTube when I'm designing courses and things like that, programs that bring older adults and, say, preschoolers together to do an art project or a sing-along, things like that. And the thing that concerns me about programs like that is that the kids tend to be a lot more active than the older adults, and also that they're not working together on a shared goal. And so while I think it could mean that the kids are entertaining for the older adults, I'm not necessarily sure it does much towards breaking down age stereotypes or, building relationships between the kids and the older adults.
Okay. Does anyone at the BC Institute focus on that?
Well, let's see. Not that I'm aware of. We have in the Boston area a Roybal Center grant, and some of those projects, the interventions might be about intergenerational exchange. But like I said, I'm not aware of or active in any of the programs.
That's just fine. Could you talk about how your interest in adolescence, how you, Erica mentioned your new research on mild cognitive impairment relating to risks originating in adolescence. Can you talk about how your work has pointed you in that direction? As in ESI, and I'm an old SI, many of us have had different career trajectories, and as someone who's had success in this particular area that you're growing into another, I think that would be a really great teachable moment to some of the people on this call.
Well, let's see. I think adolescence is of interest to me in terms of thinking about cognitive outcomes, because there's a couple of factors. One is that we know that there's a large amount of neurological development happening in adolescence. So any sorts of risk factors that could hinder that growth could be things that have long-term effects. The other thing about adolescence is, from a life course perspective, towards the beginning of accumulation of advantages and disadvantages. So if you think about children or adolescents, school quality, their family, socioeconomic resources, and things of that nature, it's sort of a building block for what those aspects might be like, what sorts of health behaviors they engage in, so on, later in life, which might indirectly affect their cognitive health later on. So I'm interested in adolescence kind of in a mediation versus direct effect kind of way, in terms of it being the beginning of looking at cognitive health.
Excellent. We've got a couple of questions in, and I guess I'll go with, since we're talking about health, what statistical relationships did you see between self-rated health, and physical health, and psychological well-being?
They're positive and modest. I want to say that the correlation was like 0.4. Generally, if you're in better self-reported health, you're in better psychological well-being as well, but it's far from a one-to-one correlation.
Okay, excellent. Another question is, well, first, thanks for the great talk. How do you feel these findings might integrate into public policy that supports the creating of NORCs and providing support services for NORCs?
I think that the research implies two things. One is that there are definitely contexts in which age integration is good. And in fact, age integration might be better than people initially thought. because, like I said, I think we're coming from this deficit perspective, assuming that having older adults in the community at all means that we're going to have greater needs for service agencies and so on. I think also notable here is the fact that the neighborhoods that overrepresented older adults were socially strong neighborhoods. So I mean, I'm a gerontologist. I tend toward the NRC approach anyway, but it certainly is the case that lots of older adults are looking for age-restricted retirement communities. So I think that there needs to be a balance between those two things and just recognition of the various social strengths and weaknesses of those two different options.
Great. Here's another question that starts with an opinion. As an opinion, I feel that populations are better served by retaining full integration in communities. As a sociologist slash gerontologist, does this ring true for you?
Yeah, I mean, that's the way I'm inclined also. I have always appreciated having older adults around me, and one of the things I miss working on a college campus is that I never see kids younger than 18. So my inclination, yes, is also to say that integration is good, but different strokes for different folks. So I think it is also important to consider contexts in which age segregation might be beneficial, or ways in which there's barriers such as age discrimination that could be broken down such that integrated communities are even better.
Okay, great. This is a compound question. I'll read the whole thing and you can decide how to unpack it. Have you seen evidence that age discrimination directly results in health risks?
I've seen evidence of age discrimination, yes. Age discrimination, like other kinds of discrimination, is clearly associated with psychosocial stress. It's clearly associated with limitations in resources and opportunities that are available to people in order to promote their health or protect their health. And it's clearly associated with various physiological indicators of well-being, such as inflammation, fight or flight response kinds of hormones, things of that nature. So, yes.
Okay, could you speak to the second part? Can you speak to the life course aspects of age discrimination? This participant says certainly the institutional of housing for the aged, both in retirement communities and skilled care, has contributed, but I think the major point here, unpacking this without context, is life course aspects of age discrimination.
Okay, I'm going to take a direction with that. It may not be what the caller asked about, so they can ask again. But different ages of people get the life course history of age discrimination is complicated because different age groups are disrespected and discriminated against for different reasons. So younger people also experience age discrimination on the stereotypical assumption that they're reckless or uninformed or unconcerned. Older people experience age discrimination on the assumption that they're impaired, incapable of things like that. So it's certain that age discrimination isn't just restricted to, it doesn't switch on when you turn 60 and go from there. It's something that affects people at various stages of the life course and is strongly intersectional with other kinds of discrimination like racial discrimination and sex discrimination.
Great. Do you think the benefits of having the elders as part of the policy mechanism helps to ensure full full representative inclusion concerning safety, zoning, health policy? You mentioned universal design in the larger community.
Yeah, I think it definitely does. Certainly, even if these policies are put in place with older adults in mind, it's the case that things like graded curb crossings are useful for people with suitcases. They're useful for people pushing baby carriages. They're useful for people in wheelchairs. So not having to step down there, for an example, is a small thing, but it affects the well-being of a large number of people.
Based on your, I'm going to follow up with this personally. Do you see in the data you played with? Did you see examples of senior? I don't want to say activism, but senior involvement in the policy process leading to change, or any associations of civic engagement with health and well-being?
So that's really good further direction.
Okay.
To my knowledge, MIDAS doesn't have any questions on that, but when I was talking before about the NHAT, National Health and Aging Trends study that does have social network roster with the ages of everyone, that survey does ask nicely about community participation and various kinds of physical adaptation to the neighborhood and so on. So I think that's a really fruitful direction to go.
Great. Is there anything that you think I've missed? I don't have any questions, additional questions coming in, which is surprising given we have the scope of professional associations, people involved in community care, Volunteers of America, Lubbock Senior Center, and people from a variety of college campuses. Is there anything else you'd like to speak to before we wrap things up?
That's broad. I don't think so.
Okay. I think everyone can see why Sara is from our first round of Matilda White Riley Early Stage Investigator Scholars. I want to thank you for the work you put into creating and then presenting today. I'd like to thank all of you for your active participation. We are, as Erica Moore told you at the beginning of the session, we are recording this. So once we convert the file and provide closed captions, we will make it available on our YouTube channel. Do stay tuned to your professional journals for Sara Moorman's new work, both coming out and in her new research interests. I'll let you all get back to your day. Thank you so much again, Professor Moorman, and thank you all.
Thanks very much, Bill.
All right. Goodbye.